So I think I might choose that we start now. So thank you all for coming. We're looking forward to an interesting session, first beginning with Dr. Hunter from Oxford, but then we'll also hear from 3 of the Pure Earth staff around the world. Peter Sharaf, who's in the Russian Far East and is also very close to what's happening in the Balkans. Alita, who is working in Armenia and has some interesting input there. And then Amanda Zingela, who is our Madagascar coordinator. So, and of course, at the end of this session, we'll go back to Dr. Caravanos, Jack Caravanos at NYU, who can give us some tips on how to be able to manage our own lives safely. So that's all ahead of us. I'm most excited, though, to introduce you all to Dr. Hunter. He's the Richard Dole Professor of Epidemiology and Medicine at Oxford University, which is the top global post for epidemiology. Before that, he was the head of the Harvard School of Public Health, working at Harvard for a number of years. It's great to have you here, David, and let me unmute you. And thank you for coming and giving us some of your time. And I'm wondering if you could just give us a little bit of an update of what you're seeing going on in the world around COVID.
Sure. Well, thanks a lot, Richard, and glad to be with you all at what is a pretty tough time in global health. It's only April 3rd, and I think this really was not on anybody's radar screen in public health until really less than 3 months ago. But in early January, we started to hear about the outbreak of a pneumonia cluster in Wuhan in China. We'd heard that before, and I don't think anybody who wasn't in the epidemic intelligence side of things really took much notice until early February. The Dow didn't take any notice until February 23rd, hard to believe, but 6 weeks ago was a record high. And I must admit, I didn't really understand how bad this was going to be until early March, when we started to get reports from Italy. So the question is, why weren't we aware and alarmed a little earlier? And I think the answer is we haven't had this experience in 100 years, since 1918-19 pandemic flu. We've had a lot of flus. We've had a lot of other outbreaks. Many of you in the US will remember swine flu in 1976, H1N1, which was another flu variant not that long ago in 2009. But the difference was that these were changes in the structure of the flu virus. And most people had some pre-existing immunity based on the fact that they had experienced the flu every few years for most of their lives. So even though people did die because there was a substantial change in the virus structure, most people had enough immunity that they either didn't die or they had a mild illness. Meanwhile, we had other non-flu illnesses, SARS 2002, Ebola, of course, Zika more recently. And what did these things have in common? Well, they had in common that they, by and large, were a problem in developed countries, and they were controlled, often with considerable effort and not as quickly as they could have been. But they weren't this contagious. And the closest to coronavirus is SARS, which was more lethal, but much, much less contagious. You pretty much had to be in very close contact or nursing somebody to catch SARS. So I think we were all sort of way too complacent. And one of the questions going forward is not only how do we get out of this, but how do we prevent it happening again? The other thing we missed was that the weakness in the health systems in developed countries, and other people are going to talk about developing countries, is that it was modeled and it was available, but again, I think we weren't really focused on the fact that if you had something that was highly contagious and even about 10 times more lethal than regular annual flu that was going to overwhelm hospitals, hospital beds, ICU capacity. And that's the key characteristic of coronavirus, is that it's highly contagious. Most people don't get very sick, but enough people get very sick that even in developed countries, we don't have the spare capacity to cope. And that's why we are taking these extreme measures right now. So where are we? So in China, there is some debate. Not everybody's convinced that the Chinese authorities are still being completely transparent about what they know and how big the epidemic was there. But the good news is that it seems like the lockdown that started in Wuhan on January 23rd has now, 2 months later, permitted them to open up travel, open up the economy, while keeping a close eye on it to try and clamp down again at the first sign of any second wave. Countries like Singapore, Taiwan, they really never had a first wave. They understood this was coming. They jumped on it soon. They did contact tracing. They're relatively small places, and so they've been able to keep a lid on it without experiencing the first wave. And the question is, can they continue to do that? South Korea is a little different in that they did have a pretty substantial outbreak. They were lucky that a big piece of it was connected with a closed religious community. And so they have been able to get on top of it and keep their economy open. What do all these countries have in common? China, Taiwan, South Korea, Singapore. Well, they all had SARS and they had it bad. And in the case of Taiwan, they had MERS. And so they had developed extremely good epidemic surveillance and intervention systems that allowed them to clamp down on it quickly. These are systems that we'd let essentially wither on the vine in Europe and the US. And so now we're in a situation where in most European countries, in the US, I think everybody understands the situation. A peak is expected, depending on the country, in sort of 1 to 4 weeks. That peak is quite plausibly going to overwhelm ICU capacity in at least some parts of some countries. Everywhere is trying to rapidly expand their beds, rapidly buy or make ventilators, and rapidly scale up to deal with the problem because nobody really had excess capacity. We were running our health systems in a way that we were trying to keep the beds full most of the time. We'd closed a lot of wards, converted a lot of medical procedures to day surgery, and so we'd lost a lot of the excess health capacity that we might once have had. So just very briefly, what are the risk factors for this being a bad disease? Well, again, I think everybody understands it's by and large worse the older you are. There's some correlation with pre-existing heart disease, certainly pulmonary disease, possibly people who are immunosuppressed. The data on that isn't really very good right now. The issues in countries that have bad air pollution problems, nobody really, I think, knows, but it's likely that if you start with a high proportion of your population who are smokers or who've been exposed over many, many years to extreme indoor and outdoor air pollution, their pulmonary function will be in worse shape, and they'll probably be less able to fight off any respiratory virus or virus that attacks the lungs like this one does. In less developed countries, what we do know is that most countries now have reported some cases. What we do know is that in many, many countries, the health systems are rudimentary. The governor of New York is calling for 30,000 ventilators. I think there's some countries in the world that might have 30 ventilators. So I think we have to be extremely worried about what will happen in less developed countries. and they will have very, very limited capacity to fight this off because it's probably not something that they can control like Taiwan and Hong Kong and Taiwan and South Korea have. We, of course, have failed to control it. So just briefly, what about the future? So everybody's asking, well, when can we exit the lockdown? So the optimistic scenario is that once the wave passes, we'll get infections down to fairly close to zero, and then be able to use the Taiwan, Hong Kong, Singapore playbook to monitor the population, monitor people who are coming into the country, and rapidly intervene and essentially lock down small clusters of people, quarantine small clusters of people who either have the infection or are exposed. Nobody I know thinks that that's going to work in the US. It's just too big, too diffuse, too disorganized. The second scenario is that at some point, the pressure to open up the economy combines with the fact that the ICUs are not actually overwhelmed, and you relax the lockdown, but you probably have a second wave and maybe a third wave and on indefinitely until you might reach herd immunity. At about 60% of the population have experienced the infection. Nobody's looking forward to that. If I had to guess, I think what's going to happen is that once the ICU capacity is built up, countries in the West will open up and just essentially tolerate having full beds at hospitals, not being able to do a lot of the regular work of hospitals, having people at risk and older people die at a much higher rate. But they'll do that because they'll decide that the economic cost and all of the health ill effects that that causes aren't tolerable. My big fear is that this will be a political decision and not a rational public health decision. Just to end on an optimistic note, I'm actually pretty confident, just on the basis of faith, that one of more of the antiretrovirals or one of more of the other drugs that's being tested will have some benefit for people who are sick. And you'd only have to cut the mortality rate in half to have a huge effect on our ability to cope with this and offer people hope. There are clinical trials going on right now. The unfortunate situation is you only have to run these clinical trials for each person for a couple of weeks because they'll either be recovered or they'll be dead. And so I think we'll have a lot of good information in a few weeks from now, and hopefully some of that will be one or more drugs that actually has some benefit once people are sick. And of course, the vaccine is the ultimate way out of this. Everybody's saying that we can't possibly do this inside 12 to 18 months. My guess is that people will be prepared to cut corners because of the economic cost. There is a danger. Those of you who remember the US experience in 1976 with swine flu, which again looked very like it was going to be like this in the first few weeks. The vaccine was rushed out, and a very, very small proportion of people did have a nasty but life-threatening side effect. And so that's caused the vaccine community to be very, very cautious about vaccines. But I think there'll be so much pressure here that, that there'll be a vaccine perhaps by the fall. And if it passes the small-scale tests, it'll at least be an option for people. And if we can get the vaccine out to enough people, and of course that includes everybody in the world and all the less developed countries, huge issues of supply and cost, then that may be the end game here that we're hoping for. So, some reasons to be optimistic, but the next few months are going to be bad, and almost particularly bad for our colleagues with less developed health systems.
Right.
Back to you.
That's so we've got an option where a vaccine will come in sometime towards the end of the year, which might give some support, but even getting it out into the poorer countries is going to be almost impossible in a rapid kind of session. Obviously, it'll go to the West first. And then the better option then might be if some of these treatments come in and show some efficacy. And that could be a longer term, a quicker, longer term strategy to be able to get out into the poorer countries. Is that kind of the way you see it?
That is the way I see it. There is some hope that some of the modern vaccine strategies can be scaled up and manufactured much, much faster than the conventional flu vaccine, for instance, which is still in most countries made by infecting eggs, and so is inherently limited in supply. Some of the, well, it's been, RNA vaccine may be able to be manufactured faster, but that's a very unproven technology.
So that's really interesting. And this tough question about how quickly to open up the economy and how much to be able to bear in terms of overusing ICU beds and allowing a certain amount of mortality is a really difficult one. But I wanted to ask a couple of other parallel things. Have you noticed what's going on in Sweden? They seem to have taken a much laxer view, and I'm wondering what you think of that.
So, I know what I've read in the press. They have taken a much more relaxed view. Everybody thinks that they're just going to experience a Western Europe situation in a few weeks. For some reason, it hasn't got there quite as fast, and they will have to clamp down, and they may wish that they'd done it earlier. But it is pretty typical. I mean, you look at the UK, and we sort of went up through the gears of different smaller scale interventions before the lockdown. And, essentially democracies are very reluctant to pull the trigger on the most extreme steps at the earliest stage. And that's probably when you have to do it to have any chance of being in a Hong Kong or Singapore or Taiwan situation and being able to not experience this first wave.
So they're really more following a UK model, perhaps, than a Taiwan model. Then
probably UK was slow, and my prediction is that they will have to be doing what everybody else is doing in a week or two from now.
Interesting. The other thing that concerns me is this issue of immunity. And there are whispers out. I had a conversation with Pam Das at Lancet just a little while ago. She's got some papers being concerned that infection doesn't impose immunity that lasts very long, perhaps only months. I don't think any of it's proven, but have you got any intel there?
So that's exactly what I've seen. The fact is we don't know, but if you look at it, there's no vaccine for a coronavirus. People argue, well, it wasn't commercially productive enough for people to invest in a vaccine because most coronaviruses are just the common cold and nobody saw a market there. I don't quite understand that, actually. But, technically it is not easy, not precedented. Why do we get a cold a couple of times a year? Well, partly because we get infected with different coronaviruses, but also because we can get reinfected with something that's quite similar to a coronavirus we've seen in the past. So it's not like flu in that sense. The, possibility, if we get decent immunity for 6 months, that would still make a big difference to healthcare workers and others. But we have to basically do the studies and see.
Yeah. And then the question also from the participants, will this come back every winter? Is it something that you're expecting to see reoccurring year in, year out, like flus and colds?
Unfortunately, that's an open possibility. That would assume that we don't have year-to-year immunity in a substantial fraction of the population. If we do get to 50 or 60%, which is thought to be herd immunity, might actually have to be a little higher because it's so contagious. The good news, again, very preliminary, is that the sequences of the viruses that are being picked up around the world are very similar. Now they're sufficiently different that you can tell a strain that emerged in China from a strain that's been affecting the US, but it isn't mutating very fast. So some people interpret that as the possibility that it won't be mutating faster than we can make immunity to it, and it won't be like the flu in the sense that it constantly mutates away from our vaccine. We have to change the vaccine every year. But that's a hope. If the immunity doesn't last for a full year, then we're going to see at least some people reinfected every year.
Thank you, David. Thank you kindly for joining us. I'll put you on mute. I'm sure there'll be many more questions for you afterwards. And please, everyone, put questions in the chat or in the Q&A. I see the Q&A too. What I'd like to do now is to introduce you all to Peter Sharoff. I don't think we're going to have a video from Peter. Peter, I'm trying to unmute you. There we go. Peter is the Pure Earth coordinator for the former Soviet Union and areas, and lives in Vladivostok, and has been running programs for us through the Balkans, through Central Asia, and in Russia for a long, long time. Peter is a dear friend and a great person. And Peter, over to you.
Thank you, Richard. Thank you, everybody, for joining us today. So here is an update for the countries that I've been working with. So just a couple hours ago, I was talking to my friend Erden in Mongolia, and he was telling me how tired he is and his family and children, particularly, of the quarantine, because Mongolia has been locked up and quarantined for a month now. So I suppose they must be really tired right now, because the first thing they did when this virus came from China, they closed the border with China. So right now they have very few cases, and mostly those are the cases of students who came back to Mongolia after the universities were closed for the quarantine. So they have like 15 cases or so. Then we have several other countries with very different experiences. Like in Tajikistan, they took a similar approach. After the virus started spreading, they closed the mosques. Like, they didn't let people together. They didn't let people to go to mosques and pray together. And all the people coming to the country, starting in February, they isolated. Like right now, they keep in isolation like 4,000 people at a time. Like, you cross the border, okay, they put you in isolation. And as a result, they don't have any confirmed cases yet. They even decided that since they don't have it, they allowed people to go to mosques and gather together again. Like, they just celebrated the New Year, the Muslim New Year, the Nowruz. They had a big holiday about that, and obviously they don't have a problem in their hospitals, pneumonia outbreak or anything like that. So I very much hope it stays this way. Then we have other experiences, like in Ukraine, it's spreading, and the country doesn't have enough tests, doesn't have the capacity to cope with it. And I think the information we have about the number of cases there is really not that reliable. In Kyrgyzstan, you would think that the country is very similar to Tajikistan. It's a neighboring country, and they have like 150 cases right now, mostly people that came from abroad. It's not a big tourist place, so maybe that's why they don't have many people infected there. And most of the people that have the virus, that people that came from other places. So they announced the quarantine. So they advised all the people to stay at home, not to contact everybody. This is the same as happened in Russia. Russia is a very big country. It has many states, kind of similar to United States. So right now in Russia, we have in Moscow region, the virus is spreading without uncontrollably because they cannot trace the virus anymore. They have too many people. They have like over 500 new cases a day. So they make people stay home. It's kind of like in New York, except they don't have as many cases yet. In other parts of Russia, the situation is not as bad yet. Like in my region, Primoria, where I live, they advise people to stay at home, but it's not strictly enforced yet because we have like 7 cases and it's not spreading as fast. So this is the situation. And in Vietnam, I was just communicating with my colleagues in Vietnam. Obviously, the situation is improving there. They're isolating all the people coming in from other countries. They're tracking all the contacts of people who are infected, and they just allow people to move around more. Like they were on strict quarantine for marching, and now they are even able to do some real field work. So that's very interesting. So this is the update for my region, and I would like to introduce Aelita Sargsyan, who is our coordinator for Armenia, and she can update for on the situation in Armenia.
Alita, I'm just trying to unmute you.
Okay. Hello, everyone. Actually, I have a couple of slides that I can share about the current situation. Let me share my screen. Okay. Do you see my screen?
Alita, it's working beautifully. Thank you.
Okay, great. So here where Armenia is situated, actually. Here is the timeline of events in Armenia in terms of COVID-19. So we had our first case on 1st of March. He was a man who arrived from Iran. And then we had several cases afterwards. So the people who were arriving from so-called dangerous countries like Iran, Italy, China, they were isolated in different places for 14 days. But actually, some of them did not tell about their symptoms or so, or they visited other countries from that dangerous countries, and they managed to appear in some places. Like, for example, a woman went to a wedding, though she had fever and so on, so she managed to infect several people there. We had several these type of cases, and because of this, the government decided to announce a state of emergency on 16th of March, and then total lockdown on 26th of March. And now, yesterday, we like the transport and metro also were closed, and we are allowed to go only to some grocery shops and to pharmacies and to have some physical activity around 500 meters around our living place. This is the curve that we have. So currently we have 736 confirmed cases. And you can see those who are testing negative, who are on treatment, cured, and unfortunately we have 7 deaths already. The dynamic shows that the number of cases is doubling in a week, which is actually not very bad if we compare with other countries. But this also means that in a couple of weeks we will have 7 several thousands of cases, which will not be very good for our country actually. So everything now is done to so-called flatten the curve. We are sitting at home. There are morning shopping hours for elderly who are more vulnerable in terms of this virus. We are washing hands, using sanitizer, and so on, which is actually being done everywhere. I would like to show you some photos from Yerevan, the empty street. And the fourth photo is showing a concert hall, which is now being transmitted to like future hospital if we need that. Actually, this photo has frightened everyone, and those who were not like following the quarantine started to follow it after this photo. I will stop sharing because these were the pictures that I wanted to share with you. Yes.
It looks like the country has jumped on this rather quickly and managed to put in some pretty strict controls. What is your ICU capacity like? Is it currently capable of? It also looks like you're early in the stage that the ramp up will come rather quickly, but what's your ICU capacity?
Actually, I don't know how many ventilators or so we have. I know that some people have donated, have bought some ventilators. Now we don't have a crisis in terms of this. And I hope we won't. But I know that several hospitals are changed to infectious hospitals now, if there will be a need and if we will have more patients than our infectious diseases hospital can handle. So we are getting prepared. We don't have any emergency situation right now. I guess everything is under control yet, but the numbers are rising.
Well, that sounds like you're on top of it for now, which is great. And I think it's appropriate we turn over to Amanda now. Amanda Zingeletwa is in Madagascar, and there Madagascar is one of the poorest countries in the world. There, I think the ICU capacity is extremely diminished, and it's a very worrisome circumstance. Amanda, can you hear us okay?
Hi, everyone. Yes, Rich, I can hear you. I don't know if you can hear me.
Perfectly. I'm glad the systems are working. Often we have trouble connecting to you, but this is great.
Exactly. That's very true. So good morning and good afternoon, good evening to everyone. Well, in as far as Madagascar is concerned, we are in a state of emergency. Even though we don't have any cases of deaths, we have 59 cases of positive coronavirus cases. The latest, which was yesterday, was 12 new cases. And the most alarming was that there's a 13-year-old boy and a 19-year-old girl, both whom were infected in a market, and that's the news that we have today. So today, the government with the Ministry of Health and also the World Health Organization, they decided to go to that particular market, which is a medicinal plant market, to go and clean it up. What we are facing today is the people are running away. Those who have been in contact with the people who are positive are running away. They're running away, and when the authorities go back to their homes to go and check on them, they're no longer there, and they are told that they don't want to be taken away from their families. As Madagascar, we have been on lockdown since the 23rd of March, but since the 30th of March, the government has been more strict. So we only have 6 hours from 6 a.m. to 12 p.m. that we can move around. And today's newspapers, the World Health Organization stated that Madagascar is probably going to be one of the first, if not the first country in the world to have more than 1 million cases, which is understandable because we have a practically non-existent health system. In as far as you were talking about ventilators in Armenia, we probably have about 24, more than 25 million, 27 million people. What we are asking ourselves right now is where will the help come from? Because as it happens, it's only the government and the World Health Organization and local NGOs and associations that are assisting. I'm not saying that international organizations are not assisting, it's just that we're not seeing them, they're not visible. And people are running away from fear. And what that has meant is that the private sector has had to work hard in donations, in as far as food, in as far as masks, and also with sanitizer, with the water, because we don't have running water in most areas. And what is also a bit, I would say, very difficult for us is the fact that, you know, Madagascar is part of, we in the top 100 of the MacArthur Foundation 100 and change fund, and we were going so good, and we had the support from all the different ministries, the presidency, the prime ministry, and so now all the attention has been removed from all the efforts that we have been making. So what we are trying to see is how can we assist the authorities to understand that the most vulnerable people in Madagascar are the ones who are affected by pollution. I don't know if it makes any sense, but that's what we are trying to do, is trying to understand, because unfortunately, this is what, when I was speaking to the platform for Madagascar health workers, they said that it's an inevitable tragedy waiting to happen. So we're just waiting for these millions of people to die because we don't have the capacity. Thank you.
Amanda, thank you. This is really worrisome. And I wanted to open up the conversation to David and get your thoughts on what Amanda's talking about there. David?
So it is devastating, and you know, I think we also need to recognize the obvious, which is that if you're having difficulty finding food, you don't have running water, you're at risk of a wide variety of other infections which are treatable, but you don't have, you know, adequate access. All of these things are going on anyway in the background. And if you can't get to a hospital or the hospital's overwhelmed, that load of other illness, death, surgical emergencies, women who are giving birth is also going on, but it's being crowded out once the hospitals get overwhelmed. And all of that's going to be worse in countries with less developed health systems than in countries with more developed health systems, but it's certainly happening in developed countries as well. But I think what may happen in less developed countries is, you know, a choice between loosening these lockdowns at the price of experiencing this devastating epidemic faster in older people, with no guarantee, as we've discussed, of being able to get long-lasting immunity, just because the cost of taking people away from their food supplies, which are tenuous, and their already very, very difficult lives may be too high in public health terms, to say nothing of the economy.
Such complicated decisions to make. Governments in these countries will really suffer. But we are trying to help Madagascar, given that it's a place that we are really concerned about. So Pure Earth and some of our partners in the MacArthur 100 and change are trying to see what we can do. And Amanda, we'll talk some more about that later today. There's a lot of calls trying to get some equipment from China there.
All right, oh, that sounds great.
Yeah, yeah. So we'll talk some more and see how we go, but it is a real worrisome kind of situation.
Yeah, yeah, thank you so much. Thank you for all the efforts, because we really are in need of all the assistance that we can get.
Yeah, thanks so much. It's good to hear from you.
Thank you very much.
I think we ought to turn over to Jack Caravanos now for an update. And there's been quite a few questions come in. Before we do go to Jack, I wonder, David, there's one question that's come in specifically for you. Could I ask for you to respond, which is, will countries need a digital health surveillance indicating who is COVID-free or immune in order to reopen the economy? I think we should get that first before we go to Jack and how you can protect yourself.
So that is one possible exit strategy for countries that can sort of get their epidemic curve down to a smaller number of manageable cases, that we all have an app. We carry our phones, maybe we're legally obliged to carry our phones. The phones through Bluetooth essentially work out who we're in contact with. And then if we develop symptoms, or we can scale up the testing and we're virus positive, everybody we've met in the last 3 or 4 days gets a message and they go back to self-isolation. So that is definitely one of the things people are looking at, because the conventional contact tracing, which is basically I get sick, I tell you who I can remember having met, somebody has to go find those people, is far too slow and inefficient. And unlike many diseases where it's only once I'm really sick that I'm highly infectious, this coronavirus, it seems that people can be infectious several days before they even know that they've got it. And then of course there's maybe 50% of people are asymptomatic anyway. So the combination of viral testing and some sort of digital surveillance is being offered as a way out. Of course, there are civil liberties issues there, but this might be one time where the public health emergency needs to trump some of those.
Thanks, David. Thanks so much. So, Jack, let me see. Are you there? Let me find.
Yes, I am.
Beautiful. Jack, do you want to give an update? Can we get you on video or?
Okay, well, I could, let me share my desktop and I can go through a quick presentation.
Okay. There's a lot of questions.
Can you see respirators?
I think yes, and there's a lot of questions. If you could go through and answer some of those questions, more than a lot of people want to hear those answers as well.
Yes, I think I got to several of them, but keep them coming. So hello, everybody. Here we are back. As you know, I'm in New York City. I'm next to a very large 1,300-bed hospital, and I'll tell you some findings in the neighborhood. I want to start with respirators because that's sort of my specialty and been in the news quite a lot these days. And what you see in front of you are the variety of respirators. The woman to the top left is actually being fit tested for an N95. And we're seeing all sorts of things. Keep in mind that N95 in and of itself means nothing unless it has a NIOSH, CDC testing and certified number. So I could buy a respirators and stamp N95 on it, and it's actually perfectly legal. But most people agree that whether it's a surgical mask or an N95, it is effective, and you sort of use what you have. So what I want to go over is some recent findings there. I want to start with, let's see here, what I'm seeing in my neighborhood. This is, I know it's a little difficult to see, but most of those white items are either surgical masks or N95s. And I don't know where they're coming from, whether it's hospital workers throwing them out at the end of a shift, which I think David and everybody would agree is not a good idea and seems to be a violation of infectious control procedures. But there are gloves, there are N95s, there are surgical masks, all sorts of litter on the streets. And I'm a little worried about this practice continuing. Oh, yes. So I want to go over some information. I'm going to take some of this from my friend Lisa Brousseau. We were in a webinar. I was in a webinar a few days ago, and she's got some nice images. So when you think of what's happening, if you look on the far left, you see that aerosols are sort of when you go to the beach and you smell the sea spray. Well, that's an aerosol. Misting, hairsprays, those are aerosols. They're wet particles. And they move about, and of course they dry up as they move through the air. So as you sneeze, the aerosol, which is rather large, slowly dries up and moves along. Aerosols are released in all body, even during a diarrheal event, you're releasing fine particles of whatever that material is. So I am a little concerned that people are sort of saying that just talking is releasing aerosols. Now I'm talking rather firmly, and it's possible that there's a little aerosol spitting coming out of my mouth, but in a normal conversation, we don't really see that. However, the 6-foot rule, the 2-meter rule is a good idea to make sure none of those particles go across. Also, in the medical world, this is very serious because intubation, any type of respiratory therapy, coughing, because of the proximity and the high volume of contact with infectious materials, this is very serious. So that's where most of the risk really is the nursing and clinical staff at the hospitals. So as someone coughs, the material flies across the room, big particles start to settle out. And the question is, what happens to those very little particles? And those very small particles, it is possible that they literally dry up and become free-floating sort of PM 2.5 size particles that are moving around the space. So a classic scenario would be what happened to someone in Westchester County in New York, where an individual was sick, was put in the back seat of his friend's car. The friend drove him 15 minutes to the hospital. And if that person in the back seat who was infected just coughed a few times, it's quite possible that you do get a situation like this, or even larger particles, and there is aerosol transmission. Because that is the big question: how much of the virus is free floating on the streets of a city, or in a living room, or behind someone that just coughed, and let's say you're walking behind them. This is something that we really don't know quite yet. What's interesting is comparing what we do at Pure Earth to this scenario. We identify sources, we figure out pathways, and then we identify receptors. And if all of these are present, we have a problem. So a lot of what is unknown today is really the source to the pathway, meaning how much of it is touching a contaminated surface, picking up a viral particle and putting it near your face or mouth, how much of it is inhaling a particle, and all this. So we really don't know. We know eating food, unless someone just coughed on it, is very unlikely to be a risk. We know that it does not live in soil. So there's a lot of things we do not know, and I hope you could share that with people, that handling your daily laundry should not be a problem at all. Handling an infected person's laundry, you definitely have to take precautions. So let's see how much time I have. There's a couple of things I'd like to say, and these slides come from Chaz, a webinar I was in the other day. This is very interesting data. David also knows all about this, which is that it seems as though in the early stages, sometimes almost pre-symptomatic, you have a lot of virus in your nasal passages, in your throat, in your bronchus, and you're releasing it at very high levels. And you don't quite know you're sick. Maybe you're just getting a fever. So the viral load seems to be very high early on, as you could see in some of these images. Just focus on 1 or 2 days since these symptoms come up and how high it is, and then tails on. This is not similar to, this is different from other infections, whether it's bacterial and viral. So this is sort of unique. Also, the fact that there's so many viral particles in saliva makes it especially risky. So, and of course, people eating, contaminating, silverware with viral particles, and touching their lips, smoking a cigarette, doing anything near your mouth really does put a very high, and you can see here the very high levels in the early on. This is rather shocking and something you should make note of, that you could read this sort of on your own here. Let me just move my boxes over here. 712 passengers on the Diamond Princess. You all remember that early incident. 47 some odd percent tested asymptomatic, meaning they were not at all sick, but about half of them had the virus and were shedding it. Some people say this number now for the population is 25%. Some people say it's closer to 50%, but it is quite possible that you have been infected and were releasing particles, and your body fought the virus, and now you have antibodies against the virus and possibly immune, and you had no idea that ever happened. So am I sick? No. Was I infected? Possibly. And until we get good antibody testing on this, we won't really know that denominator. So this is really rather disturbing, because people may have been walking around not realizing how much is going on. So I think that may be it for me on this particular topic. I will stop sharing my screen, give it back to you, and see if there's any questions you have for me.
Thanks, Jack. Brilliant as always. And I know there's a lot of questions in here. Could we just answer publicly a couple of questions? One is from, if the peak of the COVID-19 pandemic in the USA is 2 to 4 weeks, and if you are asymptomatic, will you begin to have symptoms in 2 weeks? So is there an incubation period for asymptomatic individuals?
Yes, I see David and I are both thinking this through here. Asymptomatic, what I see, when you say asymptomatic, it means you do not have symptoms. Now the question is, will you have symptoms, or will you stay completely symptom-free and literally appear healthy? So, so depending on the course of the disease, but whether you're progressing towards visible symptoms, or whether you stay symptom-free, healthy, apparently healthy, you are still releasing the virus for that term. David, do you want to chime in if you have anything additional to say?
Yeah, so the estimates are that only 5 or 10% of people in the US or the UK have been infected so far. Some people think it might be more than that. Some people think it's even less. So a lot of those people didn't know they had it. And as you said, that proportion of all people ever infected might be 20 to 50%. But most of us, if we have not been unwell in the last 6 weeks or 4 to 6 weeks, probably haven't been exposed. Some of us have been, and the only way to test is when the antibody test becomes more widely available. Some of us will prove to have antibodies to something that we never knew we had. But most of us will not have those antibodies and will still be at risk.
Thanks, David. So the answer is probably no symptoms, but we don't really know. Certainly you're going to be shedding. So that's the problem with it, I guess. Another question, any relation of COVID-19 spread with temperature?
I think I addressed some of that, but let me just make sure everybody got the answer. when you say temperature, I'm not sure whether you mean hemisphere temperature of the climate or temperature sensitivity of the virus. What we do know is hot, moist heat inactivates the virus, meaning the virus survives in cold, dry climates. Winter is cold and dry in the northern hemisphere. That's why it's particularly dangerous, as well as humans are more sensitive in winter climates because of that cold, dry climate. So we have a virus lives a lot in cold weather, and humans are more susceptible in cold weather. So logically, summertime, hot, humid climates, we'll see a natural decrease in the virus. The opposite there is the southern hemisphere, where people are very closely watching what's happening in South Africa, where they're entering their hot, humid, they're entering their winter season. Same thing with Australia. So we'll see if those numbers go up. David, feel free to chime in if there's something more.
Yeah, no, that's exactly it. Everybody's hoping in the Northern Hemisphere that it will moderate in the summer. Moderate in the summer. Of course, in the Southern Hemisphere, it's exactly the opposite. And of course, the regular flu is still there. So it's a double whammy. And the regular flu this year has been, a bit worse than normal. So that's just going to add stress. The other interesting thing about temperature is that there is a network. There's a company in the US that has distributed about 1 million Bluetooth thermometers, and you can upload your temperature on a daily basis. And they've actually done, a decent job of mapping a higher proportion of people with a fever to where we know the virus is. So that might be another one of these digital ways of trying to map and survey the spread of the virus in the future.
Thanks, guys. And one more question. Is COVID-19 man-made?
Nope.
Yes, I answered that already, but David, please answer that again.
Almost certainly not. Again, there is a suspicion now that the idea that it all started in the wet market in Wuhan, it might have been around before. And it might just be that it was that part of Wuhan that it really started to infect people fastest. But there's no evidence that it's man-made. And, the conventional wisdom is, as you said, Jack, that it's a bat virus that has crossed over, perhaps through some intermediate animal vector.
Just have a couple more questions. Saliva, what about cats? Cat to human, anything with cats a worry? Jack, do you know? David?
There does not appear to be any transmission from animals like that. Early on, people thought dogs were getting infected and getting the disease. That seems to have been shown not to be happening. Cats are perfectly safe. Walking your dog outside and bringing it inside is perfectly, I think, safe. So don't worry about that at all.
Thank goodness. There's something not to worry about. And dogs too, I think, also are safe, right?
Correct, yes.
And one last question. Again, I think we've already answered. Can anybody get COVID-19 after they've been positive? In other words, does the antibody impact decrease? And I think the answer is we don't know. We hope it stays around for at least 6 months, right? Yeah.
Exactly.
All right. Well, I want to thank our esteemed guests, Jack, David, Amanda, Peter, and Alida. Thank you very much for presenting. We will be doing these on a regular basis. I'm not sure. Jen, are you there? Can you tell us what the next plans are?
Yes. So we may potentially do one next week. We have to just kind of regroup a little bit on that. But the big day is Earth Day, April 22nd. We're working on a series of Earth Day webinars, breakfast, lunch, and happy hour. talking about our work in India, Peru, and probably stories from around the world. We're really trying to engage companies who want their employees to, we're maybe planning cleanups on Earth Day, and now we can't get out there as a group and do anything together. Well, it's a great virtual way to engage employees, to engage individuals. So we'd really appreciate everyone's help sort of spreading the word on that. We'll certainly be sending out emails, and myself and Carol could be contacted to learn more about how you can help and sign up friends and coworkers and family members for our series of Earth Day, April 22nd informational webinars.
And with that, I'd like to thank everyone for coming along. A lot of good intel here. There's lots more to learn as time goes on. So I'm sure we'll have lots more to present to you, especially as the curves start to trend up in low and middle income countries. I'm kind of terrified to see how that will go in the near future. Meanwhile, stay healthy, stay safe, stay away from each other, and wash your hands. And thank you all for attending. All the best.
Take care. Thank you. Bye-bye.
Thank you. Goodbye.
Thank you.
Thank you. Goodbye.
Bye.